I am Dr. Omar Almala, an ophthalmologist in private practice in Toms River, New Jersey. In this video, I will demonstrate a new ab interno approach canaloplasty done in conjunction with femto laser cataract surgery. In this patient, the preoperative intraocular pressure with topical glaucoma medications is 26 millimeters mercury. The 360-degree viscodilation will treat the entire natural drainage system. Catheterizing the canal of Schlemm will break adhesions within the canal and free up herniations of the inner wall of Schlemm into the collector channels. Studies ongoing by Dr. Haiyan Gong looking at the structure and function of the aqueous outflow system in glaucomatous eyes and also in UVM scan images has recently shown the importance of the distal outflow channels contributing to intraocular pressure. This procedure is not meant to replace ab externo canaloplasty. However, like ab externo canaloplasty, this procedure reestablishes flow from the anterior chamber to the restored canal of Schlemm and the collectors, and therefore enhances physiologic control of intraocular pressure. A bleb is avoided and all the associated postoperative problems. 360 degrees of the canal is viscodilated. Unlike the ab externo canaloplasty, however, here we do not use a circumferential suture tensioning of the trabecular meshwork or stenting of the canal of Schlemm. There is also no descematic window creation. Viscodilation expands the canal of Schlemm by 2 to 3 times its normal size, allowing more flow from the anterior chamber to the canal of Schlemm. In addition, it is felt that there is additional dilation of the collector channels to reestablish the flow in the distal drainage system. While MIG surgery currently addresses a small portion of the canal, it does not address the distal drainage system. You need for this procedure the iTrack micro catheter, Helon GV for microcatheter and to put under the gonial lens. I use a 20 gauge MVR blade, which I will demonstrate. Smooth jaws, intraocular forceps, loop forceps to handle the microcatheter without damaging it, and also a routine Lester lens rotator. This is the 20 gauge MVR blade. I insert it under viscoelastic through the primary cataract incision. Now this is after we have tilted the patient's head and the microscope. I identify canal of Schlemm. Note that the channel is kept slightly soft so that there is blood helping us guide the position of the otomy. A 1.5 millimeter otomy is made in the trabecular meshwork, and just slightly lift up on it to see the blood egress so we know we're in the right position. Through a 1 millimeter side port incision, the iTrack microcatheter is inserted and aimed toward the position of the otomy. A smooth jaws intraocular forceps is then inserted and the microcatheter tip is gently grasped. The tip is positioned now toward the otomy and very gently inserted, and the tip is then advanced in a 360 degree fashion. Note it is important here that your nerves keep the catheter parallel, and also note that I zoomed out here so as to allow the surgeon to observe in his peripheral vision the tip of the microcatheter as it comes around. So in addition to keeping your eye on the tip, you can also have a feeling of where you are and how much further you need to go. A smooth, continuous action of feeding the catheter in a 360 degree fashion until the tip reappears at the site of the otomy. Now it's important that the catheter have been primed before we entered the eye, and also very importantly at this point we want to reprime the catheter with several clicks until we see some Helon oozing from the tip before we begin to pull it back. Here I have inserted a Lester lens rotator and holding it up against the catheter so as to help act as a fulcrum to avoid traumatizing the canal. Every 2 clock hours my nurse turns the dial on the Helon, so we introduce Helon every 2 clock hours here as we are smoothly withdrawing the microcatheter. The microcatheter is removed. This is done after the eye has been rotated back to the primary position and we're looking straight down at it. Irrigation aspiration now proceeds in the usual fashion. The small amount of blood that is there from the initial otomy is removed, and once the eye is pressurized, no further bleeding occurs as the blood rushes out of the canal of Schlemm. It is important to remove all the viscoelastics so we don't have additional pressure spike. As some of the Helon will remain in the canal and the distal collector channels for up to 24 hours, I also treat the patient postoperatively with Dimox and also HS if they are not allergic. It is my routine here to hydrate the incision with vancomycin, which helps seal the wound, but also helps introduce antibiotic to the wound site and protect the eye.